all of you into this evening. First and foremost, can I just request everybody to please mute their themselves? Please mute yourselves because inadvertently we are listening to other conversation. Thank you so much. And at the outset, I would like to welcome the new official body of SFM Telangana, which has been instituted recently. We have with us our mentor emeritus, Professor Ashok Khurana, our president of the SFM national body, Dr. Mohit Shah, immediate past president, Dr. Bimal Sahani, our president-elect, Dr. Sunil Mehta, and our vice president, Dr. Krishna Gopal. So in the presence of all these dignitaries, I would just like to introduce the new team of SFM Telangana 24 to 26. I have the privilege of being the president of the body with Professor Kamlakar Reddy, senior radiologist, as our vice president, Dr. Shagun Agarwal, the professor and in charge HOD of NIMS Medical Genetics Unit, as our very, very dynamic secretary, Dr. Surekha from Khammam as our treasurer, and Dr. Sahiti Reddy as our joint secretary. We have a brilliant executive committee from all over Telangana with Dr. Navya, Dr. Shushma. Navya is from Hyderabad, Dr. Shushma is from Nalgonda, Dr. Aditi from Hyderabad, Dr. Jyotsna from Nizamabad, Dr. Neha Reddy from Warangal, Dr. Aarti Singh from Hyderabad, Dr. Geeta Devi from Hyderabad, and Dr. Radhika from Karimnagar. So we have a very good mix of, I think I have missed Dr. Jaya Bharati's name here, Dr. Jaya Bharati from Bhadrachalam. I'm really sorry her name is not there, but Madam is one of the senior most people who's taken all the trouble of reinitiating herself into many of the subspecialties, and we see her in many academic forums. Madam, welcome to our team and welcome to this evening also. So I would like Professor Khurana to just set the ball rolling. We've started this as an academic meeting with a very ambitious name called Mission Mangal. Thank you for allocating us the Tuesday so that we could call it Mission Mangal. The idea is to reach the stars, but we'll start from the very basics because for anything we need a good grounding. So, sir, from basics to the rockets, from the roots to the wings, that's the plan. Thank you very much for being here, and over to you, sir.
Thank you, and congratulations for the new team. We look forward to continuing vibrant activity and much more activity. We have a lot of expectations from Telangana because we have some brilliant stars in the galaxy of the executive committee, and I am really looking forward to many more members from there as well. We weren't sure whether we were going to have, with our new executive committees everywhere, just on-site meetings or a combination of webinars and on-site meetings or hybrid meetings. And the entire body at the center decided to agree that, yes, we will combine them first so that we have a greater outreach. It does encourage more people to present if they think that more people are watching. But of course, it's a different experience when it's online. So I do hope we're going to make a combination now. And I look forward to that. And I like the concept of the Mangal, the Tuesday, because it seems to be a relatively lighter day after the hectic Monday that every one of us goes through. And I'm glad you've chosen that. And the other thing I'm really proud about is that we are really back to basics. And we do understand that basics change. So it's not that basics remain the same and basics are building blocks, but if the very foundations are going to change, we better be sure that our foundations are renewed and that we're up to date. And so I'm so happy that you've chosen to have this as the subject today, and I look forward to the discussion.
Thank you. Thank you so much, sir. It's really been a mission started by one man in the beginning, but Society of Fetal Medicine is now one of the most far-reaching, like-minded individuals forum where we are really trying and doing good academic work. Thank you so much for the opportunity, sir, and thank you for being here. And with that, I'd like to take the blessings of our immediate past president, Dr. Bimal Sahani. Again, a teacher with a lot of passion and always giving us great examples in his talks. Bimal sir, a few words from you.
At the onset, hearty congratulations to the new team and my best wishes to the Telangana chapter. And of course, the name itself, the Mission Mangal, is so fascinating. I think that a lot of people would join just to even know what the Mission Mangal is all about. And that is always been your specialty, Chinmay. You've always come up with fancy, even the topics that you have given us at times have very, very fancy titles. And so it really makes a lot of difference, I know. And I really, really, really appreciate you for starting with dating. This is something which I've also been propagating for many years, and still feel that in India we don't date really well. And so, because there is nothing, I think everything in obstetric ultrasound comes secondary. The primary most thing is getting the right gestational age. And so, having a full session on that is really going to make wonders. I think everybody who attends today, from tomorrow morning, even all of them start dating well. I think you'll see a lot of difference in their lives.
Thank you. Thank you, sir. And I think sir is traveling, so there's a little bit of a connectivity issue. But we got your message, sir. Thank you so much. And we look forward to your blessings. We also have with us Dr. Mohit Shah, the president of the SFM national body. So a few words from you, Dr. Mohit.
Congratulations, Dr. Chinmay. See, I wish the entire committee an extremely fruitful scientific year, but I am sure under your guidance, it is going to be a thriving academic year. From your past experiences, you set the ball rolling, you set a benchmark. And I'm sure when you announced that Mission Mangal, I was expecting something out of the blue because you've always delivered something exceptional. Your past webinars have been so informative. And I'm glad again, as Bimal said, that you started with dating because we, in a private standalone practice, you often get patients where you're perplexed with the dating. They don't have any previous LMP, they don't have previous scans, and it all jumbles up eventually. You spend a lot of time trying to sort out things. And I believe you've chosen the right foundation where we begin with the basics and then build it up so that the youngsters who are joining us learn it the right way. I wish you all the best, and I hope the future programs are going to be even more interesting.
Thank you. Thank you
All
so
the
much,
best.
Mohit sir. And what we are planning is to have basics and some advanced. So we'll have a combination.
Yes,
So Dr. Shagun is going to do the basics of pedigree the next, and then we'll do some of the advanced topics. So we are keeping a theme of roots to wings. So we'll start with basics and then move to wings. So with all your blessings, I'm sure the team is going to take it forward. And we really have a lot of hardworking people on the team. And as you will see today, they will all deliver. So thank you for
yes.
your wishes. And can I have the next slide, please? Our MCs for the evening are Dr. Sahiti Reddy. Dr. Sahiti Reddy is a consultant in fetal medicine at Resolution Fetal Medicine Center. And she has done her DGO from Navodaya Medical College, Karnataka. And thereafter, trained in fetal medicine and is working in the field for the last 7 years. She's participated in many academic programs and also has publications to her credit. She's the joint secretary of the present team. And we also have with us Dr. Neha Reddy. Dr. Neha Reddy is currently a consultant of fetal medicine at Dr. Neha Reddy's Center of Fetal Medicine at Hanamkonda, Warangal. She's very much with us, but we are not able to see her video today. And she has been a very good student throughout her academic career. And after completing the ICOG certification course in fetal medicine, she has gone back and settled in Warangal, which is almost about 200 kilometers from Hyderabad, and started a center which is one of the very good things that's happening in Telangana, that a lot of youngsters are going and settling in the district regions and elevating the level of fetal medicine services all over. So today's evening is going to be conducted by these two youngsters. So over to Dr. Sahiti Reddy and Dr. Neha Reddy to take the evening forward.
Thank you, ma'am.
Sahiti, you're muted. No, we can't hear you. Hello? Okay, Neha, can you take it forward?
Yes, ma'am. Let me share my screen.
So Neha, can you introduce Dr. Kamlaka
Yes.
Reddy?
Yes, a very good evening to everyone. I'm here to today's chairpersons for today's academic meeting is it is my pleasure to introduce Dr. Kamlaka Reddy sir. Sir has graduated from Osmania Medical College in 1985, followed by MD in radio diagnosis from Gandhi Medical College in 1991. Sir has a teaching experience and worked as assistant professor in Gandhi Medical College, followed by Osmania Medical College from 1994 to 2002. Now, sir has his own scanning center, which is very famous, Shravya Scan Center, which has the facilities of color Doppler, 3D and 4D diagnostics since 1992 and till date. He has been a active participant and has been giving lectures and talks in states by CMEs and has published one article in National Journal. Please welcome, sir. And the next chairperson for today's...
Saiti, change the slide, please.
Our next chairperson for today's academic meeting is Dr. Jai Bharati ma'am. Ma'am is a renowned obstetrician and gynecologist practicing at Bhadrachalam. She has done graduation and followed by MD in obstetrics gynecology from Kurnool Medical College, Andhra Pradesh. She has been a gold medalist throughout. She has been received a diploma in ultrasound from Ian Donald Inter-University Medical School of Ultrasound. Has also received certification for NT scan by Fetal Medicine Foundation, UK. Ma'am is an active member of IOTA Group, International Ovarian Tumor Analysis Group, and she has also served as past Vice President, Foxy Khammam Society. Currently, ma'am is practicing in private sector in Jai Bharati Multi-Speciality Hospital, Bhadrachalam. Please welcome, ma'am. Thank you.
Welcome, Jai Bharati ma'am. I think the session is all yours. You can take it forward.
Thank you. Thank you, all the seniors, dear friends. So the first speaker for today is Dr. Chinmayi, who doesn't require any introduction. You all know her.
We'll go to the session directly.
Okay, you can start, Chinmayi.
Thank you so much, ma'am. So indeed, it is a real pleasure to be here on one of our dream meetings because SFM Telangana is a body which is extremely close to my heart, and I am so happy that in a state where I've been working for the last almost 2.5 decades, fetal medicine is now not only being accepted but loved as a specialty, and the enthusiasm that we are seeing with all the youngsters joining in, it's making us feel very good. So SFM Telangana academic meets was started with a concept of Mission Mangal. Mangalyaan was India's venture to reach another planet. And that was like the rocket science we wanted to do. But we started with concepts of dating in a pregnancy. So in this age of rocket science of medicine, why did we choose a topic so basic? Are we a bit retrogressive, or are we lazy, or are we scared of the advanced topics in fetal medicine? Because the hot topics in fetal medicine are fetal growth restriction, aneuploidy screening, interventions, anomalies, you name them, and they sound very exciting. But then we are talking about dating in pregnancy. So why did people log in for this dating in pregnancy webinar? Because despite everything, what's the date is a very big question. For example, you see a woman in the morning and then all fetal parameters fall below 5th centile. She says my LMP is 4th of June and by date she is 23 weeks, 6 days. And here is a case where it looks like this is normal uterine artery blood flows. It looks like an early onset IUGR with no evidence of uteroplacental insufficiency. And that is like a real worrying situation. Why is this baby not growing well? And when you try to think of what are the reasons of this inability of the baby to grow, you could think of a chromosome abnormality, fetal infection, some history of fever, rash, medicine intake, hyperemesis. You're scratching your brains in all angles and thinking, what is wrong with this baby? And how do I plan an intervention? When after a long time, she remembers, oh, sorry, I said 4th of June, it's actually 4th of July. So once the dates get corrected, just look at the graphs, everything falls in place. So it almost appears like correct dating is one of the treatments of growth restriction. So from time immemorial, we have been taught that first start with the history. But if the history is not correct, you might go wrong with your diagnosis. Similarly, when you're looking at a fetus, start with the dates. If your dating is not correct, everything that you do beyond that will not be accurate. So if you want to manage intrauterine growth restriction, the first thing is establish correct dating. Once you've established correct dating, you may still have a baby which is very small. And here, because you have established correct dating, if you see the way we date our pregnancies, observed versus expected. So you do the LMP basis dating, you do the scan based dating, and you look at everything and finally reach one consensus and do what is called an agreed dating. So the agreed dating, which is fixed on a particular date, and a final EDD, the expected date of delivery, which is given to the patient, is then static. You don't change it every time. So here is another case where you have an EDD which says the date should be 24 weeks, but the biometry is not 24 weeks. And therefore, you confirm the diagnosis of what is known as early onset growth restriction. So this is a case where you will worry about the fetus, whereas the previous case was one where you did not have to worry about the fetus. You had to worry about the method of dating. Once you know it is dating is fixed and this is actually early onset growth restriction, then your exercise to rule out all these problems becomes justified. Aneuploidy screening, another hot topic in fetal medicine. Everything depends on the dates, because how do you do aneuploidy screening? You look at the CRL. CRL is dependent on the dates. You look at the NT. NT is a function of the CRL. If the dating is correct, the CRL is correct, then only the NT can be interpreted. Then you go to biochemistry. And in biochemistry, this is just an example how just 1 week of disparity in the dates can turn the moms upside down. And the multiples of median are again calculated based on the dating of the pregnancy. And day in and day out, we get referrals for these patients where there is a wrong risk calculation because of a wrong date that has been entered there. You enter a date based on the CRL in first trimester, then it gets changed by the BPD in second trimester, and it just goes on and on and on. It's not unusual for every practitioner to say that we receive so many reports with was different expected date of delivery in each and every scan that the patient has done. So much so that the patients actually come and ask, what is the date now so that I can plan my delivery? Whereas they should be told your date is already fixed. When the delivery will happen will depend on how the pregnancy progresses. So pregnancy dating has huge implications, and it is one of the most essential components of antenatal care. You have to estimate the duration of pregnancy by accurate dating. Only then you can do obstetric interventions. Today, we are being accused of too many cesarean sections. And if you actually go and look into it, a lot of it is wrong dating when you've tried to do an induction of labor at a wrong time and hence not succeeded. There's so many problems with stillbirths, and that is again a lot of wrong dating because you go beyond dates without knowing that you've actually crossed the dates. So many practitioners have this habit of putting the weight of the baby as a parameter for the date, and that is extremely unfair because the baby may be growing bigger or may be growing smaller, but just the weight becoming the parameter for dating takes them into a zone where the placenta cannot support the pregnancy. So identifying the optimum timing for obstetric interventions, location of birth, delivery mode, managing growth abnormalities, everything boils down to dating. And with accurate dating, even the classification of preterm births becomes better, and comparing, these kind of perinatal morbidity indicators becomes easier. So interventions in pregnancy, I said it's already a hot topic. Why should I talk of dating? Because everything, the decision for doing these interventions are gestational age dependent. When do you want to do an amniocentesis? When do you want to do a CVS? When do you want to do an intrauterine transfusion or deliver the baby? When do you want to do a cord coagulation or continue expectant management? Everything depends on the gestational age. Fetal anomalies. We have proven evidence that gestational age at diagnosis is an important factor for managing fetal anomalies. The decisions for termination, the decision for continuation, the decision for intervention, everything boils down to dating. So when dating is so important, what are the methods of dating? All of you know that first trimester CRL is a very good method of dating. And I'm not stealing the thunder from Navya's talk, but I'm just telling that CRL is not just CRL. every scan done in the first trimester is not a justified method of dating the pregnancy. And if you do the CRL in a wrong way, you might be actually dating it wrong. And that's much more harm done in the first trimester than anything could be done. So we have a full session on how to date the pregnancy in first trimester. This maze of problems that comes around dating will only be solved when we know the right thing to do at the right time. And that is why in this session, we have taken it stepwise: dating in the first trimester, dating in the second and third trimester. Suppose the patient just doesn't come to you in the first trimester, what do you do? And at the end of it, we will summarize everything and put it together in a flow chart for dating so that you know where we are going to go whenever the patient comes to us. There are strict guidelines about how datings have to be done. And there are enough reports now to tell us that if there is a discrepancy in the methods of dating, then also there could be normal neonatal outcomes. And every day we face this problem where somebody has dated in one way, and when you put it in your software, you get a different kind of date. And therefore, a correct, appropriate software or a correct, appropriate method of dating becomes extremely important. It was nice to see this paper where even Professor Khurana is a co-author, where you have a comparison of the first trimester dating methods and their implications on the preterm birth classification. And this is an Indian study, and this is a very nice intervention. I mean, a very nice indigenous method of, dating our babies, and we should be aware of it, because indeed, although there is a lot of controversy about the population-based dating, everything, but some studies are coming up, and sometimes we need our local data to say that what we are doing is the right thing. So coming up to date is our mission in this particular academic session. And like I said, we are starting with the roots and we are planning to go to the wings. So welcome. It's a date with all of us in SFM Telangana, and have fun in your date, because the sessions that are about to come will be method of first trimester dating by Dr. Navya, methods of dating the pregnancy in second and third trimester by our senior fetal medicine specialist, Dr. Geeta Kolar. And then we go through some interesting cases where dating dilemmas led to problems. And finally, a flow chart to take home how to date a pregnancy. Thank you very much for this opportunity, and I hope to enjoy the evening with all of you. Thank you very much.
Thank you very much, Chinmay ma'am, for such a just talk on the practical insights into the dating of a pregnancy. This is the basic and essential step of our obstetric ultrasound. So hopefully after this webinar, we will be able to do it in a best possible way. So as we proceed to the next topic, I would like to invite Dr. Navya Chandrakumar ma'am to talk on the topic of methods to the methods of dating and pregnancy in first trimester. Ma'am is currently working as a consultant fetal medicine at Yashoda Hospital. She has got 8 years of experience in the field of fetal medicine. She has done graduation from Government Chengalpattu Medical College, Tamil Nadu, followed by MD in obstetrics gynecology from prestigious PGI Chandigarh, followed by a DNB. She has a fellowship in fetal medicine and from Apollo Center for Fetal Medicine, Indraprasth Apollo Hospitals, New Delhi. She has also been certified in advanced fetal neurosonogram and advanced fetal echocardiography from FMFI and ISWAG respectively. She has also been certified in clinical genetics by ICOG. She has, to her credit, various awards and achievements and publications in reputed national and international journals. Please welcome, and you can start the topic, ma'am.
Thank you, Neha. Just I'm sharing my screen. Good evening, one and all. Directly jumping into the topic, dating in the pregnancy in the first trimester, that is between 5 weeks to 14 weeks. So we all know now the knowledge of gestational age is very important for optimal antenatal care and for improving the pregnancy outcome. And it is very well known that 30% of women attending an antenatal clinic have uncertain or unreliable menstrual dates. So it is very important, that is in the first rather than the second trimester, have shown that reduction in the number of unnecessary inductions of labor. So there are various papers published in the White Journal and various other journals talking about the importance of dating in the first trimester and its impact in the further planning the pregnancy. So everyone comes to a conclusion that the potential benefits of a correct ultrasound dating in the first trimester includes proper scheduling and interpretation of certain antepartum tests and timing of appropriate obstetric care for aneuploidy screening and other pregnancy tests, the improved performance of first trimester screening for chromosomal abnormalities, and determining the appropriateness of fetal growth, which has already been discussed, and I'm not going to talk in depth of all this, and designing interventions to prevent preterm birth, that is reducing the number of pregnancies classified as preterm and reducing the incidence of post-term deliveries and related morbidities. From Asian population, Asian history, the detection and dating of pregnancies are done by early signs of pregnancies like tenderness of the breast, nausea, vomiting, etc. Later, the beta-HCG was developed where it is now available as a home pregnancy kit, which is done in the urine sample or a serum test, and the gestational age is estimated as 3 to 4 weeks at the time of a reliable HCG pregnancy test. However, the most commonly used method for the proper prediction of estimated delivery date is by last menstrual period, and we all are very aware of Neglect's rule, where EDD is calculated from LMP plus 1 year minus 3 months plus 7 days. This rule, the very utmost drawback of this rule is that it assumes that the periods are always regular and regular 30 days cycle is taken and the pregnancy lasts for 280 days. The second method is for assisted reproductive techniques, we estimate the date EDD by date of conception, and the important one is ultrasound estimation of date by using parameters like gestational sac and CRL, and where CRL is considered to be the most accurate and definitive method. So as I said, gestational age estimation by using the timeline of normal ultrasound appearance of a gestational sac, yolk sac, fetal cardiac activity, and CRL. In this table, it is very clear that a gestational age can be estimated from the appearance of gestational sac. That is, it is expected to be around 4.5 to 5 weeks of gestation, and yolk sac become apparent around 5 to 5.5 weeks, and the CRL, that is embryo, can be seen with a cardiac pulsation around 6 weeks, from which an estimated date of delivery can be predicted. And how to use gestational sac as an estimate for gestational age is that gestational sac first, as I said, first becomes apparent around 4.5 to 5 weeks of gestation, and the gestational sac size is measured in 3 dimensions. The mean sac diameter is taken to predict the gestational age, and it is also expected that growth rate of gestational sac is approximately 1.1 mm per day. However, mean sac diameter measurements are not recommended for estimating the due date in the current scenarios. And then what is the most accurate method is that the gestational age estimation by the CRL. That is, an embryo or a fetus in the first trimester, that is a CRL up to 13 weeks and 6 days of gestation, is the most accurate either to establish or confirm gestational age. That is, a measurement of CRL has an accuracy of approximately plus or minus 5 to 7 days. It is also said that the measurement of CRL are more accurate when it is measured earlier in the first trimester. And the first equation is done by Robinson and Flemings in as early as 1975. Later on, several studies has been proposed and validated different CRL equations and has been reported since then. For example, in this paper, they have talked about the gestational age estimation by Crown Rump length, and they have included more than 1,300 studies, out of which the 4 studies have been taken as the highest quality scores. For example, McLennan, Robinson and Fleming, Sahota et al. And Verbeck, and they have concluded with the gestational age estimation with the CRL. However, in our daily routine practice, we most commonly use methods of Hadlack and Robinson's, which is available as a presets in most of the machines and software we use. And this is already, Madam has shown this. This is a very good paper I come across while doing this presentation. This is a paper which has developed a gestational age estimation from an Indian population-specific dating formula. This included the cohort of Garbini, which is the ongoing pregnancy cohort of North Indian women, to study the preterm birth. And they have got a gestational age estimation from this Indian population and using CRL. And what are the higher bodies says about, like ACOG, AIUM, and Society of Maternal and Fetal Medicine talk about how to predict the EDD is that the ultrasound measurement of an embryo or a fetus in the first trimester, that is around 13 plus 6 weeks, is the most accurate method to establish or confirm. And if a pregnancy is resulted from the ART, that is IVF conception, then the EDD should be assigned using the age of the embryo, that is date of conception. For example, for a day 5 embryo, the EDD would be 261 days. And for a day 3 embryo, it would be 263 days. They also conclude that a pregnancy without an ultrasound examination that confirms or revises the EDD before 22 weeks of gestation should be considered as a suboptimally dated. So how to measure an accurate CRL? A mean of 3 discrete CRL measurement in the mid-sagittal section should be taken, and maximum length of the cranium to caudal rump measured as a straight line. It is said that CRL of greater than 84 mm, which is approximately around 14 weeks of gestation, the accuracy of the CRL to estimate the gestational age decreases, and dating changes for a smaller discrepancy or appropriate based on how early is the ultrasound performed. Early is the ultrasound, most reliable is the gestation age estimation. And when the patient comes with the unsure of LMP, please do not change the LMP, which is a natural constant. EDD should be estimated based on the ultrasound examination, ideally before 14 weeks. And this guideline says that when a patient comes less than 9 weeks, if the ultrasound measured CRL has a discrepancy with the LMP rating of more than 5 days, a redating should be considered. And if a patient comes between 19 to 14 weeks, that is 13 plus 6 weeks, and a CRL discrepancy of more than 7 days, then you should consider for a redating. So how to date a pregnancy of a twins? This is the same way. Ideally, the CRL should be taken everywhere, and it should be ideally between 11 to 13 weeks. That is 45 to 84 mm CRL should be taken for dating the pregnancy. And in pregnancies conceived spontaneously, that is spontaneous twin pregnancy, larger of the 2 CRL should be used for the estimation of gestational age. In twin pregnancy, which is conceived by IVF, as we already discussed, date of conception should be taken. There are also studies which actually have a controversy between why can't we use a smaller CRL or a mean CRL, which takes into account of both the fetuses. This particular paper has been widely published and has been accepted by all. They say that the CRL of a larger twin to date the pregnancy leads to a slight overestimation, and a mean or a smaller twin will lead to an underestimation. So thus a consensus was made from the most common choice to use a larger CRL, because this protects against missing a diagnosis of IUGR in the smaller twin. So how to date IVF pregnancy? Now we are very clear. These are the most commonly used presets or the softwares we use to date a pregnancy. So I'm just going to give you some example. I'm not going into depth of it. These are some examples. Here, all the 3 examples are IVF conceptions. And in first 2, the date of conception is used as a parameter to estimate the EDD. You can see here the date of conception and estimated delivery date is by the date of conception. Here also the embryo transfer date is used, which is a day 5 embryo, and the agreed dating is based on the ET date. But particularly in this report, you can see the gestation age has been taken from the baby, from the fetal size, and the EDD was taken from the CRL size. So now with this discussion previously we have had now, so we know that these 2 are the right ways to date a pregnancy in IVF conception, which is always a controversy and confusion for us. And this is not the right way to do with the baby size. And this particular paper talks about how a CRL measurement in early trimesters can impact the assessment of growth. They say that as small as 2 mm can make a major impact on the assessment of growth. So what is then the appropriate way of CRL? As mentioned, baby should be in a mid-sagittal section, and a cranium to crump length should be taken to measure the CRL. So now with the discussions, we know that these are all the wrong ways to measure when the baby is in the coronal section or in an upside down. And these are all the right ways to measure a CRL, and make sure that it should be taken in this proper plane, which has been set by the guidelines. So the take-home message is that CRL, first trimester, less than 14 weeks, most accurate method. And in twin pregnancies conceived spontaneously, larger of the 2 CRL should be taken as a measurement to estimate the gestational age. And in IVF conception, either it is a single child or a twin pregnancy, EDD should be taken from the date of conception, that is using the embryo transfer dates. So I always have this confusion we always get this kind of a scenarios in dating a pregnancy, particularly in IVF conception. What to do, how to take as a date, what to be taken as a date of conception when there's a sequential transfer of embryos. Should we take a first embryo transfer date, or what would be the correct date of conception for 2 embryo transfers? It's a routine practice, and it is, I don't know, like day 3 and day 5 embryos has been clumped together and they are transferred on a single day. And then what would be the date of conception in these 2 scenarios? I just opened this question to the forum, and let us discuss this in the later on. So thank you.
Thank you, Navya ma'am, for such an in-depth talk about the first trimester dating. I would now request Dr. Ajay Bharti ma'am to give some expert comments on first trimester dating.
So, Navya, I have a question.
Yes, ma'am.
So, a patient with irregular cycles, she is an educated patient. As soon as the pregnancy test is positive, she has come to you at 7. You have diagnosed this as 7 weeks pregnancy. She again came after 2 weeks, and you have again done a scan at 9 weeks. So which CRL you take, at 7 weeks or 9 weeks, to confirm the dates? She is an irregular cycle.
Ma'am, when the CRL is measured in the right format, even if it is 7 weeks, I would prefer to go for the 7-week scan. So if a CRL is being measured by the outside elsewhere, then I would prefer to go for the NT scan between 11 to 13 week CRL, because the plane of the baby and how a guideline-based measurement of the CRL should be taken into account. So if I personally did a scan for the patient, and when we have a quality check on ourselves, then the 7-week scan should suffice.
Okay, right. Thank you.
I think what Madam wants to say is, if you have 2 different gestational ages, because perhaps what Ma'am wants to say is maybe at 7 weeks it's not that big and there could be chances of error. But what Navya has pointed out is, at every stage in pregnancy, there is a method of doing it correctly. So if we do it in the longitudinal section, exclude the yolk sac, take the right angles, actually, ideally, there should not be a discrepancy even at 7 and 9 weeks.
Yes.
The problem, what happens is, most of us get so excited to see the fetus inside and the heartbeat there that we look at the cardiac activity, we see the gestational age, and somewhere just write down, you scribble 6 weeks or 7 weeks and just write SLF, FCA present. So that should gradually change into a habit of anyone doing that scan, measuring it, because for the fetal medicine specialist, the first time to see the pregnancy is at 11 to 14 weeks. But if the obstetrician at 6 weeks has done some dating, we are bound to follow it because we have to respect the early pregnancy scan. So the message that Navya wants to give everybody is that everyone should be measuring in the correct parameter. So this confusion of 7 weeks, 9 weeks, 11 weeks should not happen. At every gestation, the measurement should have been accurate, like she showed in her pictures. So it's an interesting discussion, and she's brought up more.
The report should be along with the picture.
Yes, and the quality check has to be there. So we have to make our own quality check. So especially obstetricians, because that first scan is often done by obstetricians. So that would be a good thing to do. All right, let's move to the next talk. Thank you so much, Navya. Thank you, Jai Bharti ma'am.
Now I take the pleasure of inviting Dr. Geeta ma'am, who is the Director of Department of Fetal Medicine at Fernandez Hospital, Hyderabad. Ma'am has done MD from Osmania University in 1987 and has joined Fernandez Hospital, a tertiary perinatal center, in the same year. And she herself started the Department of Fetal Medicine in 1998. Ma'am, I request you to take over and start the session now.
Madam, you are muted.
No, I think she's just setting it up.
Yeah, I'm just setting it back. Just sharing the screen. Thank you.
Thank you so much for coming in, ma'am, because for many of us in Hyderabad, she's one of the last words in fetal medicine. Somebody who has started the science here in the city. An extremely, extremely lovable person, ma'am.
Good evening. Thank you, SFM. Thanks, Chinmay, for the kind words. I think we all learn from each other, and I'm still learning. I will never say I'm the final word. I would never. I'm still learning everything every day, with every speaker. Right. Thank you, Nabir, for this talk. नहीं,
आप मिठाई लाओ बेटे की मैंने कहा बेटे की सगाई हो गई
and we have everybody.
I am so sorry. Many congratulations for many good things that are happening in the background, but please mute yourself.
Okay, now after finishing the first trimester, we would how to date in the second or third trimester. First, let us see why date. We have heard this now. Then I would discuss why do we need to, if we have dated it, or why do we really need second trimester dating? How accurate are we? What are the simple algorithms for assigning a due date if a woman has not had a scan in the first trimester? How do we assess fetal weight and growth with standard biometry in the third trimester? So like we just heard, the traditional one is person tells you the LMP, you take off the Naegeli's rule, and then you give her an expected date of delivery, and you have the pregnancy wheel, which again, you put it on LMP, and you know what is the date of delivery, and as per today, what is her date, or what how many weeks she is. But remember, we are assuming that all women have only a 28-day cycle, and that all women will remember their last menstrual period. Does this really happen in our practice? We are not taking into account the irregular cycles that mothers have, the PCOS, which many women have, conceptions during lactational amenorrhea, people taking pills for various religious functions and postponing their periods. Remember what we've just heard, first trimester dating. If LMP and CRL are matching, you just assign her an expected date of delivery. And once you have assigned it, do not change it in subsequent scans. So whatever the report says in the first trimester, then you put that, and according to the pregnancy wheel, or instead of now putting the LMP, put your EDD and calculate how many weeks she should be, and is the growth corresponding. So that's the first message for me. We just heard about why should we date? What is the importance of dating? Because this is the fundamental to provide high quality antenatal care. A mother will first ask us, so when will I deliver? So that's our first fundamental quality care assessment. And when dates are inaccurate, we will do tests inaccurately, and we just heard about how the mom values will change. And then dating can affect the precision of rates of preterm, postterm birth, and rates of small for gestational age fetuses. So it is, if anything that this whole basics is trying to tell us, is dating is fundamental. Dating has to be done properly. Dating can then diagnose prematurity. Dating can then diagnose fetal growth restriction. So we need, and once we put the date, do not change it. Now let's come to this case. Gravida 2, para 1, live 1, conceived during lactational amenorrhea. On examination, we find the fundal height is about 22 weeks. That means this mother has presented very late for prenatal care. She has not had any earlier ultrasound assessments. Now, what do we do? How do we proceed with obstetric management in this scenario? Do we give her any scans? Do we ask for quadruple? How do we do? So what we do is do fetal biometry on ultrasound. And the ultrasound examination in the second trimester helps us in determining an approximate gestational age. It also enables simultaneous fetal anatomical evaluation. So it is a greater advantage. But it has a greater variability and complexity, and the error that you would get is plus or minus 2 weeks. So I may be 18 weeks, 20 or 22. So that's plus or minus 2 weeks it is. And the biometry that we use, standard biometry is biparietal diameter, head circumference, abdominal circumference, and femur length. All of us need to remember the correct plane of PPD measurement. We just can't have a round with no intracranial structures seen. we have to either do a transthalamic level or at the transventricular level. Both are almost giving similar measurements. So either way, whatever you're comfortable, you can do it. It is a cross-section at the level of the lateral ventricles or thalami. The midline forks should be seen. Again, the anterior part should be equidistant from the posterior part. That means the midline fork should be equidistant. And at the proximal 1/3, you have it cavum septum pellucidum bisects this midline forks. And it should be a rice oval rugby or football shape, and skull contour should be regular. So we should have this plane when we are taking the biparietal diameter. Only then can, like we just saw, how's the CRL? The baby should not be flexed. It should not be too extended. You should not include the leg. Where do you put the cursors? So unless you do this correctly, you will not give the correct gestational age or interpret the measurements correctly. So the caliper, once you have the measurement, the caliper placement is from outer to inner border without including the skin. And BPD is not really used in the practice to give a gestational age. What we prefer is head circumference. Head circumference is also measured in the same plane. Again, we do not include skin. The third measurement is of a femur length. Again, this is best measured after 14 weeks. You should see both the ends of the metaphysis very clearly. The longest axis of the ossified diaphysis is then measured. The distal femoral epiphysis should be visible, but should not be included in the measurement. And the angle should be corresponding to the technique of reference chart. And we recommend 0 to 15 degrees to horizontal. The abdominal circumference is actually the most difficult measurement. And again, it is more important in the third trimester rather than in the second trimester because it is more predictive of fetal weight. So it is again a true axial section at the level of umbilical vein and portal sinus. Stomach should be seen. Kidneys, cord insertion should not be seen. And here we can either measure with an ellipse tool or a 2-diameter method. And the calipers should include skin. That means outer to outer. So we have taken all the 4 measurements. What do we do with these measurements? We have measured BPD, HC, AC, and FL. For all the measurements, see that the images are clear with sufficient magnification. We have correctly depicted the landmarks which are needed to allow precise caliper placement. And now try to assign gestational age for each parameters from the tables. AC is not used, so you look at compare BPD, HC, and FL ages. Remember that there is this discrepancy about plus or minus 2 weeks. So you have taken multiple fetal growth parameters. Now you see if HC and FL agree. One may be 18.6 weeks, another may be here if you see 19 and 18.6 weeks. That means both are agreed. Both at the 15th centile, our problems are solved. It's a straightforward. We say she's about 19 weeks of gestational age. But what happens if there is dolichocephaly, brachycephaly, then you either underestimate or overestimate. That is why it is ideal to use the head circumference. So ISWAC practice guidelines also tell us that HC with or without femur length can be used for the estimation of gestational age in the mid-trimester when a first trimester scan is not available and her menstrual age is unreliable. So this is very clear. We use HC and not BPD, not FL mostly. But if HC and FL agree, we can go and give this gestational age. But what happens when both HC and FL disagree? When HC and FL disagree, go back, review. That's why we said store images, zoom them, put caliper placements. Review the HC and FL sections and caliper placements. Repeat the sections, remeasure, and see if they are really genuinely discrepant. Because small FL below the 5th centile may be associated with skeletal dysplasias, aneuploidies, or early growth restrictions. And small heads may be associated with microcephaly and spina bifida, where you may need to refer them for further assessment. These are short femurs, which can be associated with a lot of skeletal dysplasias. and small heads could be associated with microcephaly. So how accurate are we when you date this in the second trimester? BPD, it's slightly less accurate because we said it can have varying shapes like dolichocephaly and brachycephaly. So the error could be between 7 to 12 days. HC is the most accurate single measurement between 14 to 22 weeks. AC is the most variable measurement, and it is affected by fetal growth if there's a very early onset fetal growth restriction. And if you take an average, then you will miss out on fetal growth restriction because the error is plus or minus 15 days. FL may again vary, like we have seen examples with aneuploidy, ethnicity, and skeletal dysplasia. So again, the message is use HC to date the pregnancy in the second trimester. Another measurement you can use is the transcerebellar diameter. Again, the landmarks are the same. It's a slightly oblique lower down measurement where again the landmarks are the thalami, the cavum septum pellucidum, and the third ventricle. It is like a butterfly-shaped cerebellum, 2 lobules on either side of the midline with the central echogenic bones. It exactly corresponds to the gestational age till about 22 weeks, and then the size increases. Having completed with confidence ultrasound in the second trimester, we would try to go to the ultrasound in the third trimester. Fetal biometry in the third trimester is subject to a much greater individual size variations than in size. So if you see the gestational age, if I take a measurement, it is about plus or minus 3 weeks. So pregnancy dating after 24 weeks is called unreliable. Here, we are using the biometry to assess size and weight and not going to assign a gestational age. And subsequent examinations will try to assess the velocity of growth. Accuracy of gestational age assignment is reduced considerably, and the confidence intervals are plus or minus 3 weeks. So if I say she's now 32 weeks, she may be 29 or even 35 weeks with growth restriction. The error is so huge. So we must be really not giving an expected date in the third trimester, but actually measuring them, going by the weight, and again monitoring them again after 2 weeks. So the third trimester ultrasound, it is very difficult to assign an accurate estimated fetal estimated date of delivery. Do repeat the scan 3 to 4 weeks later for growth because you need to rule out FGR. We just saw this chart where after 28 weeks, if you take BPD, HC, AC, and FL, the error could be more than 21 days. Again, we use the same biometry, BPD, HC, AC, FL, and then we calculate estimated fetal weight and plot it on a graph to see how many weeks she should be. And then if the gestational age is not known, we have to recall her and look at it. The estimated fetal weight is most reliably calculated by the Hadlock formulas, but as the weight increases to more than 3 kgs, the percentage of error also increases. Remember, we need to plot these on the growth curves. After you measure, if the date is known, if the earlier EDD is known, plot them on this. These are standard population-based growth reference charts. And you compare the distribution and see whether the growth is on the 5th centile, 50th centile, or above the 95th centile, and say what is the growth velocity. Is it approximate for gestational age, average for gestational age, or is it fetal growth restriction, or is it large for gestation? What is the accuracy? Ultrasound fetal weight estimation is currently the most accurate method available for obese and non-obese. Despite this, errors in weight estimation of about 20% are possible. So dating, like we said, is the least reliable method with an accuracy of plus or minus 21 to 30 days. Risk of redating a small fetus that may be growth restricted always exists. So based on this, you cannot base your management decisions because you may miss out FGR. If you give her an estimated fetal days, she may come with an intrauterine fetal death because the baby was fetal growth restricted and you gave her an estimated fetal weight, which is 4 to 5 weeks later. That's why the decisions need to be guided by careful consideration of the entire clinical picture. You need to be, the baby needs to have close surveillance, repeat ultrasound, Dopplers to see appropriate interval growth, and based on this, you can then adjust the EDD. There are some other articles, especially in Indian population, which have tried to say you can see the kidney lengths also, because this particular article was, I just read that it said the mean kidney length rose consistently, especially in the third trimester. They have found it very reliable because consistently with gestational age from 27, it rose to about 38 or 39 weeks. So it is as accurate. So probably we should be using it. And this is a very reliable measure of gestational age, and it is a very simple technique to determine the gestational age. In third trimester pregnancy, where the mother has an uncertain LMB, the length of fetal kidneys may be extremely helpful in determining the gestational age. Another thing we often look at is the ossification centers. Because when you're not very sure, is she 32, 35, 36? Is she 36 with the growth restriction and the measurements are corresponding to 32 weeks, or she's actually 32 weeks? At that time, you can take the help of these ossification centers because distal femoral epiphysis appears around 32 to 33, but occasionally, even by 29, we may see it. And the size increases linearly with gestational age. So if a distal femoral epiphysis diameter is greater than 7 millimeter, it indicates certainly that the gestational age is 37 weeks. And if your measurements are coming at 32, 33 weeks, please see that this is not FGR. So certainly do the Dopplers and be very sure you're not missing FGR. Visualization of the proximal tibial epiphysis indicates a gestational age of at least 35 weeks. Sonographic detection of proximal femoral epiphysis has been correlated with a mature lung profile on amniocentesis. So these mothers who do not have a properly dated pregnancies are called suboptimally dated pregnancies. And how do we manage them? When they do not have, then they should, any woman who's not had a dating of pregnancy before 22 weeks is called suboptimally dated. And here you cannot unnecessarily do a preterm section. You cannot really go on waiting. So all these mother needs a serial assessment of fetal weight and gestational age every 3 to 4 weeks after the initial ultrasonographic study. Follow examination is intended to support the working gestational interval fetal growth assessment so that you do not miss out on fetal growth restriction. So to conclude, ideally pregnancy should be dated by CRL between 10 to 13 weeks, 6 days. That means 32 to 80. Pregnancies between 14 and 24 weeks should be dated by HC and FL, provided these two parameters agree. Once you have assigned an expected date of delivery, please do not change it. And gestational age should not be assigned if you're scanning a mother after the first time after 24 weeks. Assessment, again, the errors, if you've done a CRL, the error could be just plus or minus 5 to 7 days. Second trimester, plus or minus 2 weeks. Third trimester is very unreliable because the discrepancies may be more than 3 weeks. And measurements should always be performed in a very standardized manner in the correct planes with the accurate placement of calipers. Accurate dating requires correct sections, correct caliper placement, and preferably not to report an inaccurate measurement because you could mislead this ultrasound and the clinician with this misleading ultrasound. So measure in a very consistent manner, identify standardized anatomical landmarks, place calipers at predefined points, and once you have these measurements, plot fetal biometric measurements on graphs against the expected values of gestational age to be able to see if this growth is appropriate, less or not. Thank you.
Thank you, Dr. Geeta ma'am. That was a very nice deliberation by all the three speakers. Shabashia to Chinmayi, dear Navya, and Geeta ma'am. A mother carries a fetus in her womb for 9 months and in her heart the entire life.
Very nice.
So if this 9 months journey is safe, the entire life would be happy. But this journey starts with dating. So this mission Mangalyaan is a very catchy name. So I'd like to add a point. So you all know that Mission Mangalyaan is the first India's interplanetary expedition. So this is actually a nickname. The actual name coined by ISRO is Mars Orbiter Mission, and ISRO abbreviated this as MOM. So now you all agree with me as fetal medicine doctors, we always deal with moms. So there is one more similarity. The team mom is a female-dominated team. It is actually the true success story of Indian female scientists. And SFM Telangana is also a female-dominated society.
Thank you.
So,
Thank you, sir.
Ritu Karidal is the rocket woman of India, and Chinmayi, our Chinmayi, is the rocket woman of SFM Telangana.
That is very kind of you to say, ma'am. But at that note, we'll welcome Dr. Kamlaka Reddy also here, because although we are female dominated, we have some very strong,
I agree.
male members
So
who
sky
are
is not
also
the
supporting
limit.
us.
Sky
True,
is
true,
not the
ma'am.
limit. Okay.
True.
So I
Thank you, ma'am.
invite expert comments from the seniors, Dr. Kurana sir.
Thank you, ma'am. So with that, we move to the discussion after the 3 talks, and then we will have a case presentation. So, sir, shall we do the discussion now or have a trade presentation and then move on to the discussion?
I think we'll go on with the trade presentations. Conferences International, can you have?
Thank you, sir. So we've just finished with the 3 lectures, and we'll have a quick round of discussion to bring into perspective the next case presentations. So, sir, any thoughts?
Excellent presentations, and I think we needed this kind of a so-called revision, but more than a revision, it turned out to be an insight, because concepts change with time, and we now know that yes, what was there day before yesterday is no longer true today. And I really congratulate the presenters for bringing this out so beautifully. There's one thing I'd like to add, and that is that the future is here already with artificial intelligence. And what we have realized is that there are things that a computer can see that you and me cannot. And therefore, we have now started using artificial intelligence to date pregnancies. And we already have an excellent formula, which is now getting validated between 6 and, well, I should not say 6 as yet, but at least the one which is getting validated is between 10 and 14 weeks of pregnancy, where we upload an image of a crown rump length approximately, without it being exactly, onto a computer. It then analyzes not the measurement, but analyzes the texture of that fetus and tells me how old is that fetus. And the error rate then is less than a day. And you can well imagine how accurate that is. And the validation should be through. Now, this data is not from outside the country. This is Indian data, and it's on a mixed urban and suburban population from Gurgaon, which is close to Delhi. It's a team I've been working with for the last 7 years, and we finally have it in place. Should be in clinical use by the end of the year. So that's what the future is all about. I thought I'll add that before we have the final word with the discussants. But a fabulous presentation.
Thank you, sir. And that's really good news that you've given us, because that's what, it's not just basics. It's a lot of new things that's coming in to stabilize the basics and to strengthen the basics, because that's when we will reach bigger heights if our feet are right there in the ground, and then we can look up to the sky properly. So we have a few questions. So the first one was, if we know the embryo transfer date and the age of the embryo was 5 days, how many days should we subtract from the ET date to get the date of conception, 5 or 4? Any one of our experts can actually answer that, because this needs an expert input.
It's 5 days, ma'am. If at all the date of transfer is today, we have to subtract 5 days, taking account of today also.
Today also. Fair enough.
Yes.
And honestly speaking, 5 and 4 is not going to be hugely different. So let's not really get confused. Whereas the things were very clear the way it was presented, less than 5 days actually doesn't make so much of a difference on the dating, but still, if you want accuracy, 5 days. So there was another question on how should we be dating the a pregnancy with anencephaly. Now, Navya has already written there that anencephaly. So again, one little message, what are we dating for? Whenever we do a procedure, we should understand what is the target. So the target is not just achieving a dating. The target is to achieve a dating so that we do good things in that pregnancy. What is it that we will do in a case of anencephaly? So it's a lethal anomaly. All we need to do is find a safe method of discontinuing that pregnancy. So if it's a very early pregnancy, the dating really doesn't matter. If it's somewhere in second and third trimester, which should not happen in today's day and age, but even if it is, then you have female length, you have abdominal circumference, something or the other to assist you just to understand where you are in terms of the size that an obstetrician has to deal with. But I don't think there is a lot to do with. I hope the seniors agree. And if there's any contention there, please do tell us. So the other questions have been answered in the chat box. So we'll move on to the next session, which Dr. Aarti Singh is going to take us through. So Dr. Saiti, can you introduce Dr. Aarti? Unmute yourself, Saiti.
So I welcome Dr. Aarti Singh, who is a consultant at Fetal Medicine at Fernandez Hospital. Ma'am has done MBBS and MS and senior residency from SGPGI MS Lucknow, fellowship in obstetrics USG from Mediscan Chennai, postdoctoral fellowship in high-risk pregnancy and perinatology NB in New Delhi. She has seven publications in Index Journal, and her special interest is invasive fetal testing and therapy. Welcome, ma'am, and then request you to start sharing your slides. Dr. Aarti, ma'am.
All the concepts that we make ultimately go down to clinical application. So Dr. Aarti is going to present to us some cases where we have learning points which are primarily based on the dating dilemmas. So over to you, Dr. Aarti.
Very good evening to all. I will be taking you through some interesting cases related to the dating issue, and in next 10 to 15 minutes, we will try to resolve the dating dilemma. I hope I'm audible.
Yes, ma'am.
Okay. So the first case, she's a primary mother, referred to us from 200 kilometers from remote area to our hospital for anti-scan. She was 12 weeks according to her early pregnancy scan, which was done at her native place. But we can see what happened at our hospital. It was the single life fetus 34 CRL, making the date of 10 weeks of gestation. We disclosed the report to parents, but they were anxious, thinking that baby is not growing properly. Here it is 10 weeks, although it was told by her primary consultant, it is 12 weeks. So what is happening here? Why there is discrepancy? So we gone through her early pregnancy scan report, and we found that dating was done on the basis of the gestational sac, means a diameter. So now the question comes, is this a standard practice? Not at all. Gestational age determination by a mean sac diameter is now obsolete. It is no longer in practice. And we are interested in baby. We are interested in fetus. We are not interested with the baby surrounding. That's why we want to look the baby directly and to measure the physical, to do the physical assessment by measuring the crown rump length, which is the most accurate method of the dating. So this is the learning lesson from this case one. So we should avoid such practice to do the gestational sac measurement and the due dating. So it is a standard practice always and always. It is the crown rump length is the most accurate method of the dating. Moving to the next case. She is gravida 2 with history of 1 abortion. She came for anti-scan at 12 weeks. Dating was done as per CRL, which is the standard method. So we can see the report. It was done and she was asked to go to the fetal medicine center for the anti-scan. Here again in our center, she was only the CRL of 43 mm and it is 10 weeks, 6 days. According to our scan, although she was told by her primary consultant, it is a 12 weeks around. So again, discrepancy has been made. So what could be the reason? Although it was performed as per protocol, CRL was taken in consideration for the dating of this pregnancy, even the mistake was made. So what could be the reason? We reviewed the early pregnancy scan report and we found that it was done, although it was done on the basis of the crown rump length, but it was 3.4 mm. On that point only, dating was performed. So now the question comes, how to rectify such kind of mistake? So what is the best time to date the pregnancy? So various guidelines has given, Canadian guidelines, it is the 10 mm of the CRL is the onward is the best time, but we should always follow the ISWOG guidelines. According to the basic training, ISWOG, as very good lectures are there. According to that, the 10 weeks to 13 weeks, 6 days, when the CRL is 30 to 84 mm is the best time because baby is in the neutral position. If we try to do the dating before that, actually we are underestimating the gestational age because baby is hyperflex at this point of time. We are actually measuring the crown neck length rather than the crown rump length. So the learning lesson from case 2, the most reliable period of gestational age estimation is when the CRL is 30 to 84 mm, corresponding to 10 weeks to 13 weeks, 6 days. Moving to the next case, it is a little bit easy. Mother has irregular history of irregular period and she was 15 weeks by LMP. She came for the scan and in the scan, CRL was 59 millimeter, which is corresponding to 12 weeks, 4 days. So nowadays software are available. They can calculate the gestational based upon the CRL. So by LMP, she was 15 weeks and by CRL, she was 12 weeks, 4 days. So disparity of 2 weeks, 3 days. So as per AIM guidelines, my 1 minute. My PowerPoint is not seen.
We can see your slide.
Yeah. It's not getting bigger. Yes. Sorry for the interruption. So as per AIM guidelines, between 9 to 13 weeks, 6 days, if disparity is more than 7 days, we have to redate. So we did the same thing and the final diagnosis was made as per the CRL, as per the ultrasound finding because disparity is very big. So it is a very clear-cut case and there is no, it's a very simple case, but just I want to share one tips and tricks for the doctors who is working in the remote area where the rating software is not available. So what to do in that scenario? So always there is formula. We should remember CRL in centimeter. Again, it is gone. Sorry. CRL in centimeter plus 6.5 is gestational age in weeks. So if the CRL is 59 mm, it means we have to, it is 5.9. Here you should keep in mind, it in mm, you have to convert in centimeter, 5.9 plus 6.5. So C is 12 weeks, 4 days. So just I want to share because many doctors from the SFM Telangana who is working in the remote area and for them the software may not be available. Now moving to the most confusing time, second and third trimester, gestational age determination and related issue. So first case, this mother, Primey, she came to us at 5th month of gestation and by LMP she was 20 weeks. So we can see her parameters, head circumference, abdominal circumference and femur length, all are falling between the 18 to 19 weeks. So mean gestational age was 19 weeks, 2 days. And if we see the AIM guidelines, we have dated accordingly. Discrepancy is only 5 days. So we can go with the LMP dating and she was assigned as 20 weeks. But life is not always that easy. We can move to the next case. 27-year-old primary mother. She has a history of irregular period. She came for the first time in the pregnancy at 28 weeks 6 days by LMP, and we can see her scan finding. In our hospital, she was found between all the parameters was falling between the 21 to 22 weeks. So discrepancy of 7 to 8 weeks between the LMP and the USG dating. So what to do? It's a big dilemma. If we go with the scan dating, she's AGA and she's 21 weeks 5 days. If we go with the LMP, she's 28 weeks 6 days, and it will, because the most of the parameters is below the 5th centile, C can be the case of the fetal growth restriction. How to resolve this dilemma? So we can take help of the non-traditional biometric and non-biometric parameters. That is pulse of sonographic pulse in estimating the gestational age during the, especially it work in the later part. It helps you to narrow the biological variability when we are establishing the gestational age, especially in the later part of the gestation. Already it is discussed by Dr. Geeta, transcerebral diameter, epiphyseal ossification center appearance is time, and the multivessel Doppler, amniotic fluid, as a long list of the things, and we can take help of that things in our estimation of gestational age in the later part of the pregnancy. So we did the same thing here. You can see the transcerebral diameter is matching with the LMP. So always transcerebral diameter from 14 to 24 weeks, it is equivalent to the gestational age in week. But although she is 28 weeks, but it is more or less, it is matching. So something, we move to the next non-biometric, non-traditional parameters, which is amniotic fluid. And we found that is a oligohydramnias. We performed the multivessel Doppler functional assessment, and we found that the uterine artery notching was there. And apart from that, the umbilical artery Doppler was very abnormal. It is a end-diastolic flow and the MCA redistribution and DB reversal, A wave reversal. So it is telling we are dealing with FGR. Actually, it says the 28 weeks 6 days according to LMP we have to follow. And in this case, non-biometric parameters are help a lot, and we could come to the diagnosis without missing this important entity, fetal growth restriction. And then that day only she was delivered because of the abnormal Doppler finding. So the learning lesson from this case, when the dating is done in second and third trimester, always there is possibility that fetal growth restriction can be missed. So careful consideration of entire clinical picture is very important. If we are dating the pregnancy, doesn't mean that always doing the scan and going with that finding only. We should think our approach should be holistic. So look for the non-traditional biometric and non-biometric parameter, which we have discussed just now, and which helped us in this case to come to the diagnosis. And close surveillance is equally important at the 3 to 4 weeks interval to look for the interval growth. Moving to the next case, which is the last case, cis gravida 2 with history of one abortion came for a scan first time to our center, and the LMP was unknown. We can see the parameter, head circumference, AC, it is, and the transcerebral diameter, all are falling between the 19-20 weeks, but the FL is 15 weeks, 6 days. So there is big dilemma. Head circumference and AC is agree with each other, but FL is disagree. So what to do? If we include all three according to AIOM guidelines, head circumference, AC, and FL for the dating calculation, for dating estimation of the dating. So C is falling between the C can make the gestational age can be the 17 weeks 6 days. And if we exclude the FL, because it's a very skewed finding, abnormal finding, then C will be 18 weeks 6 days. So how to go about that? So always there is a rule, when two people are saying the same thing, the evidence will be stronger. So we did the same thing. Because the two things are agree, we went with that, and FL was excluded from the dating process. And C was, not only that, we have excluded the FL, being a fetal medicine person, not only we are dating, we have to see the baby as a whole. So why this FL is so skewed, why it is so abnormal, so less? So we have to think in that also, this prospect in mind. And maybe we are dealing with the skeletal dysplasia, and we performed the detailed skeletal survey and transthoracic diameter, and we found that all long bones were smaller. And the diagnosis was made at the skeletal dysplasia. So in this case, apart from dating, we have made one extra diagnosis, which is our duty. So the learning lesson from case 6 is that in the latter part of the pregnancy, always we should see whether the parameters are agree with each other or not. If disagree, don't jump and exclude that parameter. Try to repeat and reproduce the measurement. If still disagree, then consider the significance of genuine discrepancy. Individualized approach according to the specific parameter. If AC is not, if AC is very smaller, we should think in terms of growth restriction, we all know, and a large microstomic baby, and we should not include AC in that scenario for the dating, because it is a very skewed value. Now FL. FL again should not be used when it is very small, and we should calculate the gestational age on the basis of the head circumference and the abdominal circumference. And when the head circumference is smaller, we should think in terms of microcephaly and exclude this parameter for calculation of the gestational age. So I hope I'm clear, and this discussion will help you to resolve the dating dilemma. Thank you so much.
Thank you, Dr. Aarti. I think it was simply superb. Your selection of cases was so nice. You brought across all the problems that we face on a day-to-day basis in dating. So I think that was a really, really illuminating session. Any comments from the seniors? Jai Bharti ma'am, you want to say something? Khurana sir, you want to say something?
This has been a wonderful session, Chinmay. I mean, what cases you've highlighted throughout your webinar has been to the point, and you've driven it quite well. All of the experts, in fact, have driven the message quite well that dating has to be, you know,
Yeah, I think. Thank you, Dr. Mohit. Dr. Aarti, you can stop sharing. I think we got a lot of information from your cases. And like I said, the final take home will be a flow chart, which will tell us exactly how we can apply all that we have learned today in every sense. And if all the seniors approve that flow chart, we will make it into a small message-like thing and circulate it to all our members. So it is going to be presented by Dr. Aditi Shastri. She is an MBBS from Pune and a DNB in OBGYN also from Pune. and did her fellowship in fetal medicine in Rainbow Hospitals, Hyderabad, and received Fetal Medicine Foundation accreditation eventually. She was also a consultant in Rainbow Hospitals at Delhi prior to this, and is now a consultant at Resolution Fetal Medicine Center in Hyderabad. Her areas of interest are fetal intervention and therapy, and management aspects and smooth functioning of fetal medicine units. So I really value her and that interest in our unit also. Thank you, Aditi. And please present your take-home message for everyone.
Thank you, ma'am.
I'm sorry, I'm in bad network.
Yes, I could gather that. But thank you for your good words.
So as we all know, excuse me. Right. Dating, as we all know, is on a lighter note, very, very, very important towards a very good outcome, especially in this modern world. So when there can be books for dating for dummies, and when we can have doctors writing research papers on how to get dating right, I'm really privileged to be giving you a shortcut flowchart for dating after all the people who have spoken before me. So I would like to sum it up like this. When the patient comes for her first date with you, history. You can't possibly be missing whether this was a spontaneous conception or an IVF. Like we have all seen that in an IVF conception, we'll be dating by the embryo transfer date and the age of the embryo. While in a spontaneous conception, you can't just discount the LMP. I mean, there have been papers which say, do we need to know the LMP at all? But yes, we do need to know the LMP because common sense is always common. So please don't forget to ask her LMP and look at the strength of that history taking, whether her cycles were regular and how was the strength of her recall. Then, of course, the first trimester, which is more golden than anything else. And we look for the differences between a twin pregnancy versus a singleton pregnancy. So essentially, both of them are the same. You would prefer the CRL. The only thing we need to remember in twins is that the CRL of the larger fetus is what has been largely agreed upon. As Dr. Navya said, there are controversies as far as the smaller fetus is concerned, but largely, I mean, most bodies say we look for the CRL of the larger fetus. So we prefer the early pregnancy scan. And as everyone has told us that we look for CRLs which are more towards 7 to 9 weeks of gestation. And then, of course, the golden CRL of an NT scan, the CRL between 43 to 84 millimeters. Some reports like the JOGC says that if the CRL is more than 84, but it is still within 14 weeks, then you could also consider using the BPD. What we need to remember is that we won't change dates if we are sure, if the patient is sure of her LMP and the difference is less than 5 days and you have a good early pregnancy scan in place. You won't change dates again if the patient is sure of her LMP and her EDD is calculated and the difference is less than 7 days for a first trimester scan CRL. Then coming to the second trimester, if she comes to you for the first time in her second trimester, you would check if the pregnancy has been dated prior to 22 weeks. If it has, then you will not change dates. You will just go ahead and confirm if the first trimester dating has been done well. As far as between 14 to 22 weeks is concerned, excuse me, you would prefer, so there are different papers give us different opinions. The American College and the AIOM say that we should go for composite biometry. But as Dr. Aarti has rightly pointed, composite biometry has its own weaknesses where the FL could be shorter or the, AC is not measured well. So as far as the ISWOG is concerned, they have recommended the HC with or without an addition of a FL. Again, here we must remember that the accuracy of these datings is 1 week to 10 days. So we won't change dates unless your difference in dating is more than that. If the pregnancy has not been dated prior to 22 weeks, then we'll consider it as a suboptimally dated pregnancy. So between 22 and 28 weeks, again, we go for HC as a method of dating with or without the addition of an FL, or a composite biometry, which is again controversial. The variability here now goes up to 2 weeks. So don't be in a hurry to change dates unless your difference is coming to more than 2 weeks. You can use other methods such as the TCD, combination of your biometries, kidney length, and as all the seniors have pointed out, FFICs of the long bones, all these other measures here can act as your accessory weapons. And beyond 28 weeks, don't be in a hurry to use any real method to change dates. Use all the possible methods that we have told you before. Most importantly, use your common sense. Don't be in a hurry to change dates. It would be better you wait, see the baby again after 10 days to 2 weeks, and then come to a final date for this baby. So the take home messages today would be: the farther backward you can look, the farther forward you are likely to see. So history is everything. Don't forget your history in trying to get a ultrasound date. A picture is worth 1,000 numbers. So what I want to bring out is that many times we just look at an ultrasound report and just take whichever EDD they printed out on that report to be the final date. I would request all of you just flip back to the images. The CRL between whatever that number may be completely and most positively depends upon the image being taken by a standard method. So please look at the picture. If the picture is not really done by a standard method, then your CRL is not that great after all. Check, double check, recheck. There are free calculators available. I think we've all been there with typo errors, with bad recall, bad dates put on while making reports. So there are free calculators available online with the Fetal Medicine Foundation, ISWOG calculators. All you need to do is put in the date of the scan, put in the CRL value, and you will have an EDD. So please make that extra effort. And a stitch in time saves 9. So last but not the least, read it early, not late. And definitely don't be in a hurry. If there is any confusion, it's still worth waiting for those 2 weeks before you come to a date. Thank you.
Thank you. Thank you very much, Aditi. And with that, I think our first Tuesday session, we have served whatever we had to serve. This flow chart, if it is approved, then we are happy to make it into a small soft copy and send it to all our members. So some words from our seniors before I invite our secretary, Dr. Shagun, to propose the vote of thanks.
That was the
Well,
most brilliant synopsis, Dr. Aditi. The most brilliant synopsis of the entire webinar. Kudos to you. Well done.
Thank you so much. So with dating, we'll move on to other things in coming sessions. And like Kurana sir said that, our membership drive is not just a drive to ask more people to come in into the fold of SFM, but indeed, it's really an unusual organization where all of us learn to encourage each other and go on from step to step. So like we are saying, from roots to wings. And my journey in SFM has been like more than a decade now, and it's always been so rewarding. So these are all the membership benefits of SFM, and I would request each one of you to encourage more and more people to join the Society of Fetal Medicine. With that, I would invite our Secretary of SFM Telangana, Dr. Shagun Agarwal, to propose the vote of thanks for today's session.
Thank you, Dr. Chinmay. So it's my privilege to deliver this vote of thanks for our the launch of our Mission Mangal. So first of all, I would like to thank our mentor emeritus, Professor Khurana, and all the national body chairbearers, Bimal Sahni sir, Dr. Mohit Shah, and Dr. Krishna Gopal, for giving us this opportunity and for being the fuel behind our rocket. So we hope that we will scale maybe the planet, or maybe, you know, go beyond the galaxy. Let's see where it takes us. So, so with this, like, I would like to thank all of the speakers today. So the chairpersons, the seniors, Dr. Jai Bharti ma'am, Dr. Geeta ma'am, who have been here today, and the MCs, Dr. Sahiti, Dr. Neha, and the speakers, Dr. Dr. Navya, Dr. Arati, and finally Dr. Aditi, who really, I mean, that was a brilliant algorithm. So it was really good. I think so thank you to all of you. And also thanks to the Conference International and Vishal, who, as always, have, you know, allowed for the seamless conduct of this meeting. Thank you for the trade partners, Strand Genomics, who have been supporting this program. And
thank you so much for all our delegates who logged in and gave us the joy of having more than 250 people at one time. And even now we have about 150 logged in, which is a real privilege for all of us. Thank you so much. We look forward to all your love and blessings forever. Khurana sir.
Well, congratulations.
Before we wind up.
Congratulations and thank you very much. This is a much needed effort. For those of us who wanted to know, we do have these webinars which will get posted within 2 to 6 weeks onto the SFM YouTube channel. Do watch it again there. It'll be a ready reference for you whenever you need it. And of course, for all of you who are not familiar with YouTube, do subscribe to the channel. First of all, become a member, and then subscribe to the channel, and then say you like it and let others know that you like it. Not because of any other reason, but it's nice for others to learn the same things as we are learning. And thank you, Chinmay, for taking this forward. Congratulations to the entire Telangana team. It's indeed a pleasure to be here. I'd also like to thank our trade partners today, and they've promised to support the rest of the season as well. Thank you very much for a fabulous session.
Thank you. Thank you, everyone. It was really a joy to bring the session back to you. Thank you.